Thank you, Thomas. It is Andrea Sarkozy here, and I think maybe we will start with your talk because then you can leave us if you wish to.
Thank you.
So, if anybody has any questions, please go ahead. So we are, I mean, I really appreciated very much your talk. We just have done our first case here in the hospital, and that was for a reason why we have waited so long. And more specifically, first of all, we are a big VT center. That means that we are doing a lot of ablations, and we have new technologies regarding pulsed field energy sources. So I would like your opinion. What do you think in the area of pulsed field ablation in the ventricle? How relevant is still STAR? One thing, and a second, it's you didn't talk about complications. But I think this is a very important issue. So there are cases described 9 months after the procedure of gastrocardiac fistulas with irradiation of the inferior wall of the ventricle. And there are, according to some centers in the Czech Republic, 20% need, 25% need, again, 1 year after the procedure for mitral valve surgery. So first of all, regarding both, so the mitral region, what's your explanation about that, and how do you think we can avoid that? The mitral valve problems. And so the second is, do you think there will be the same in the area of pulsed field ablation? It will have the same importance?
Sure. Thank you very much. Very, very relevant questions. So yes, definitely complications are something absolutely crucial for this kind of novel strategy treatment. And actually, before we move to prospective studies, we perform a lot of on safety. Also in my center, we were performing the study, which was very much focused on safety. Of course, the mitral valve issue is a topic, and whenever possible, we try to avoid irradiating, the valvular apparatus, also arteries, coronary arteries. It always happens within the team of electrophysiologists, radiotherapists, and also structural heart disease experts. It's also kind of a balance, how much we can help with arrhythmia and what kind of complications we can expect. And whether, even if we know that there may be a problem with mitral valve, for example, can we fix it with MitraClip or any other, valvular approach to fix the problem? So yes, this is definitely something worth looking at, and also it's very important that the patient should be really well followed up after the start treatment. And of course, it's a standard procedure in the trials which are currently going on, that we really want to see how is patient doing and see the patient in the clinic from time to time to catch up the problems. In terms of the pulsed field ablation for ventricle, I would still say that STAR should be treated as a, kind of a final solution if there is no other option for the patient. So, and for now, it's treated like this. So we have patients who underwent 4 or 5 unsuccessful ablations, endocardial, epicardial. So still, I think it's going to be like, treated as the kind of a final way to solve the problem for the patient.
All right. Any questions from the floor? I have a hand here. Please come forward. He has a mic.
Yeah, thank you. Is it?
It's on, yeah.
Yeah. You were talking about risk, but you did not mention the risk of introducing cancer. I was very keen on this method, but when I first heard 25 gray, I was shocked. I'm more familiar with the imaging. And we are going now significantly below a milligray to protect the patients. So you hit the lung, you hit the esophagus, and I would say it's very likely that you will introduce cancer. So I would say, okay, for people above the age of 80, that might be a good choice. But well, I'm 71, I wouldn't go for that one.
That's true. I mean, still the observations. Thank you for the question. The observations are quite short. We don't have long-term follow-up in patients treated with STAR. Even radiotherapists were very hesitant on going to 25 Gray, and for all their life they try to avoid heart. And in STAR, we are focused on the heart. So it's a change of a paradigm. But yes, in fact, the most of the patients are elderly patients, and they have many comorbidities, mostly heart failure, ejection fraction of 15, and shocks, of course, because this is also inclusion criteria to include the patient into the trial. But yes, we need long-term follow-up to see, how much oncological problem we can induce, yes or no, and how much after STAR treatment.
That was a challenging question. A star is born, but a star can die too in the long term.
That's true.
Just as a follow-up, how is this star born, actually? How does someone come up with the idea to irradiate the heart, an organ that we try to avoid at any cost when radiating oncological pathologies?
Yeah, so it all started in the US. Actually, the first big study published in Name was from the US, and I think it came from the clinical need and this very specific and demanding, challenging subpopulation of patients with VT and intractable arrhythmia. So this discussion across disciplines and how we can use modalities using oncology for cardiovascular problem. It was born because of the clinical need, I would say.
Thank you, Thomas. We didn't mean to, to be very negative, or because I very much appreciate your talk and also the expertise you have. So we didn't mean to, to bring the technology down. We are, we are just being careful, and I think some more studies and long-term results are necessary and working together. But we appreciate very much your presence and talk on a Saturday. So thank you very much.
Thank you very much. That was a great pleasure.
We have Carlo on the mic. Okay.
No, I have a question for Professor Boni.
Yeah, please.
So we can...
I'll give you this.
Yeah, you can close the...
Yeah, Thomas, thank you. You don't need to, if you don't want to, you don't need to stay.
Thank you very much.
Enjoy your Saturday.
Yeah, enjoy your congress.
Just a short question before the break. What do you think is the main challenge today to apply 3D printing in medical world, talking about a regulatory problem?
That is a fair point, because I think that it can enter as a patient-specific device, so following the regulatory of the patient-specific. Therefore, you're regulating the process and not the device itself that comes out. The main thing is that up-to-date materials that are 100% accepted in the surgical room are still to be found with the right properties in terms of flexibility, rigidity, and biocompatibility. Because you have a lot of material that are flexible and elastic enough to do as a guide. Give you an example also for the cardiac mask that we've been working on. But at the same time, do they have the right property in terms of thermal resistance, electrical properties, biocompatibility? So I think that there's still some work to be done to define which is the material that is able to satisfy all the points at the same time.
Do you think that 3D printing will be able to avoid because when you go to industrial production, you have a quality control, and some pieces doesn't go through the commercialization. In a 3D printing, the quality control is well defined, or we should be more stressful in this?
I think that at the end of the manufacturing, the quality control should be the same regardless if you're using casting or 3D printing, because it's the geometry of the object, the interesting part. So as it would be checked for molding or let's say subtractive manufacturing, I think that should be done for the 3D printing, because I've been dealing with printers with different qualities, and you really can see outcomes that are way different corresponding to the object that was printed.
And in your experience, what is the impact of operator dependent? I mean, The same printer will respond to everybody the same?
It's how you tell the printer to work, because the printer is a machine, and machines
What is, in your experience, the impact of the operator? I mean,
if you
how bad
leave
can
the-
be somebody?
it's designing. At the end of the day, it's the same thing as saying if someone design and instruct the machine in the wrong way, the machine will act accordingly. So I think that someone should be skilled in order to define.
Because there is no education around this at the moment, codify,
I mean, regulatory speaking, okay. Education depends.
Regulatory
because-
speaking on education also. So, there is not somebody say certifiable 3D printing for medical approach.
No, we are breaking the balls of our students way much, and I'm looking at them in this moment, because sometimes if the design is not made properly, well, the machine can totally give errors. It can basically destroy the nozzles itself. It can corrupt the calibration that has to be done at the beginning. So yes, there's a lot of things to be careful of, both for the machine and for the final use, because we're talking about medical devices. So.
We have a question on the left.
Yes, my question. So you mentioned there is still a lot of research to do for developing these 3D printed materials. So my background is engineering. So if an engineer wants to, let's say, give you that material, do we know already all the properties that we need? Because otherwise we can do endless testing. And so an engineer needs all the, let's say, the specifications, the mechanical properties, the electrical properties, thermal properties. Do we have any idea? Otherwise, we run maybe a long time around an unknown point.
Being an engineer myself, so I'm not a doctor, surprise. But one thing that I can tell for sure is that sometimes we wanted to know the mechanical properties of material that are nowadays available for 3D printers. And the answers are always a fog of, yeah, you can ask to the provider, but they will not answer you properly. So this is not always clear even in the materials that are available, because they don't want to give a certainty of mechanical properties if the mechanical properties can be altered by how the printer is working as well. So.
Do we have an idea, let's say, I mean, what is the, let's say, the parameter space?
I mean, depends on what you want to do. If I want to do a
But
prosthesis,
application one, we need this kind of material properties. Is that already known? Because otherwise, we are going to do a lot of trial and error, especially when you don't know what the 3D printer material is.
we're on the same side, engineers over here. But no, the point is that this is a very nice question, because which property are we looking for? It's the main question that we as well ask to the surgeons. Like, I work mainly with the implants. So what are we looking for? Because the implants are made in materials that are way stiffer than the bone. So this is already a complication for the interface. So what do you want to do? That's why you've seen maybe some of the implants were with the structure that was more empty inside. So also to decrease the structural properties, to make them more similar to the bone. But all of this is still open. So if I knew the answer to the question, I would be rich probably in this moment. But
We're gonna wrap up with just one last question regarding Gen ECG from Professor Sarkozy.
Yeah, so yeah, because it was a little bit break. So, but I think it's these virtual ECGs are very interesting. In my mind, a clear application of this is education. So also because of privacy issues, and I'm thinking about so teaching in a way with this. With these simulated ECGs, once it works, instead of showing ECGs of patients. And the second one, for example, also evaluation. Do you have any experience on that?
This one, please.
So yeah, on the subject of education, I think synthetic data has potentially vast uses, because it kind of overcomes any of the issues to do with confidentiality and patient privacy, because you can utilize that data for any purpose that you see fit. There's essentially no way of kind of identifying the patient based off that. So yeah, I think education is certainly going to be a potential use for not just for ECGs, but for synthetic data in general. And then, sorry, your second question was?
Well, I don't remember, but I was, so something correlated to teaching. But the second one is the other, I'm asking you, so because in biological structures like human, the limit between abnormal and normal is, we know that there is no cutoff, that this is an abnormal ECG, that's a normal ECG. How do you deal with that? This is the last question, but
Yeah, so I mean, I think, there will be a spectrum and it will be patient dependent in terms of that. And I think that's probably a reflection of perhaps the limitations associated with ECG diagnosis and the way in which we've previously thought about it. So as clinicians, we're naturally inclined to try binarizing things, but I think it's always a spectrum. And I think in trying to encompass that and perhaps looking at things like predicting future risk as with a level of uncertainty is probably the best way in which to approach that. But I mean, that's very much open and up for debate.
Time for coffee.